Good morning, friends. Welcome all the delegates on this wonderful, pleasant Sunday morning. We have a galaxy of faculties here on the topic of acetabular fracture. Welcome, Sushruth.
Hi.
Welcome, Sushruth. May I request Sushruth Babudkar sir to please welcome and start the proceedings, please?
Yeah, are we online already?
Yes.
Okay. Good morning, everyone. I, on behalf of Vidarbha Orthopedic Society, am delighted to have AOPAS come and join us and share their academic knowledge and expertise with all of us. So thank you very much, Pradeep. Deeply appreciate your precise planning of academics and putting the timetable together. It was 2 weeks back when Nirbhay, our North Star as far as pelvis and acetabulum is concerned in Nagpur, requested me to do it. So I gave him all the responsibility to organize it, and that's how this has happened. It's my wish as an incoming president of Vidarbha Orthopedic Society that our junior colleagues who have special interest in subspecialty, they form some academic contribution, they hold such meetings, and that's how Nirbhay is instrumental in doing so. So all yours, AOPAS, all the very best. Have a great time. Next 2-3 hours, there are lots of webinars happening everywhere, but pelvis and acetabulum has always found a special place in my heart. Goes way back during my training. Anyways, without much wasting your time, all yours. Enjoy, guys. Thank you.
Thank you, sir, for the introduction. So this is a joint venture between the Vidarbha Orthopedic Society and the Association of Pelviacetabular Surgeons. We have a very good symposium that is lined up today. And to introduce the faculty, we have the first talk by Dr. Sarvanan Manoharan, who practices in Chennai, and going to talk on how I read the X-rays. Then we are going to have a talk on how I read the CT scan by Dr. Harish Makkar. Dr. Pradeep Kothadia from Solapur is going to talk following on the decision making in acetabular fractures, and I will continue how to plan the surgery with respect to instruments and implant. In the second section of the webinar, we have Dr. Lokesh from Bangalore, who is going to talk on geriatric fractures, which are nowadays exploding in numbers all around the corner. We have Dr. Dinesh Kale from Belgaum, JNMC Medical College, who is going to speak on tips and tricks for reduction of posterior wall and posterior column, which are pretty common fracture in day-to-day practice. We have Dr. Sunil Gavaskar from Chennai, Dr. Ashok Gavaskar from Chennai, and he's going to talk on anterior wall and anterior column fractures. To complete the symposium, the most important thing is to manage the complication, and Dr. Dhaval Desai from Surat is going to take us through that. So I invite now Dr. Sarvanan Manoharan to talk on how I read the X-rays. Sarvanan, can you share your screen?
Okay, can we start, sir?
Yes.
Yeah. Respected delegates, so this welcome to all on a Sunday morning for a very exciting session of acetabulum webinar. To start with the proceedings, we'll start with the basics of how to read a proper X-ray. So the objectives of the presentation are to emphasize the importance of an X-ray, what are the special views of an acetabular fractures, draw those specific lines, and to classify those fractures. So as we all know, X-ray is very important for an orthopedic surgeon, moreover in an acetabular fracture, because it's a mode of communication. It helps in classification, and moreover, it helps in planning of the surgery. Just with looking at the X-ray, we'll be able to identify what are the approaches we are going to do, what are the reduction techniques we will do. And intraoperatively, there is no other tool apart from X-ray, and your C-arm is going to, that is only going to tell you that the reduction is adequate, and the other thing, whether the whatever screws we have put is not inside the joint. And again, follow-up is X-rays are essential. So we know the basics of what are the landmarks of a pelvis. So arbitrarily, acetabulum is classified into two columns. So this one is the anterior column, which is shaded as yellow, which includes the ilium, the superior pubic rami, the anterior part of the acetabulum, and the pubic bone. Again, the posterior part is marked in violet. So this is it involves the ischial tuberosity, and the acetabulum forms a Y-shaped structure. The anterior column and the posterior column meet at the superior dome of the acetabulum. With this introduction, we go into the three views which are needed to study an acetabular fracture. So the AP view, which is always the HP view, and the obturator and the oblique iliac views. So the AP view is the standard view. To say it is a proper AP view, we should know that the entire both sides of the pelvis should be included in the X-ray, and it includes the proximal femur up to the lesser trochanter, and the spinous process and the pubic symphysis should be in the midline. So both sides, the obturator foramen should be of equal in size. So that is again an important. Then only we should start commenting on. We have to draw a few lines. The first one is the iliopectineal line, which starts from the superior part of the pubic bone and it ascends up over the superior pubic ramus, and it forms a thick and passes over the thick sciatic buttress bone, and it reaches the. If you have this, we have to draw this line on an X-ray. So this is the iliopectineal line. As if we superimpose on a pelvic model, this forms the anterior column. So this any break in the iliopectineal line will say us that there is an anterior column of the fracture is disrupted. So again, this is an ilioischial line, which is another line which ascends from the obturator foramen, inferior part of the obturator foramen. We can draw a vertical line which again leads to the sciatic buttress region. This is nothing but it is formed by the X-ray beam passing tangential to the inner part of the or the medial wall of the acetabulum, which is called actually as the quadrilateral plate. Since it forms a part of the posterior column, so we say that once that ilioischial line is disrupted, it means that there is a posterior column fracture. So then we have the roof or the sorsal, which is a curvilinear line starting from the lateralmost part of the acetabulum. We should not be confused to the dome of the acetabulum, which is a 50 to 60 degree arc or a sector of bone of the superior part of the acetabulum, and the roof forms only the 2 to 3 millimeter of the most cranial part of this particular dome. Then we have two lines starting from the anterior lateral edge of the acetabulum roof. So one is this line, which forms a posterior ring, and the one line which is a faint line which will be able to difficult to trace, which is the anterior rim. So why the posterior rim and the anterior rim, they don't overlap each other because of the anteversion of the acetabulum. So this is the posterior rim, as we said before. Then we have the teardrop, which is again in the radiological imaginary marker, and it has two limbs, the medial and the lateral limb. The medial limb is formed by the inferior cotyloid fossa, and the lateral limb is formed by the medial wall of the obturator canal as it forms goes into the quadrilateral plate. So in a summary, from the AP view, we have to draw the iliopectineal line, which represents the anterior column, ilioischial line, which represents the posterior column, the acetabular roof, the teardrop, the posterior rim, which is very prominent, the anterior rim, which is little faint. So these are the lines which needs to be drawn in a AP view of the pelvis. Then we have the special views called the obturator oblique views and the iliac oblique views. So we know that in orthopedics, everything is 90-90. So you want orthogonal views of everything. So here we have the obturator oblique view, which in this view, we will be able to see that the obturator foramen is well prominent, and we are not able to see the iliac bone at all. When compared to the obturator iliac view, where the obturator foramen will not be seen, but the ilium will be in full profile seen. So how it is taken is the same side of the hip is elevated to 45 degrees. So the X-ray beam meets the body at the angle of 45 degrees. So the landmarks here are, this is the pelvic brim, which constitutes the anterior column. The anterior column, which we say from is well seen, and any fracture which is here, which takes place in the anterior column is better seen in an obturator oblique view, and we will be able to see the intactness of the obturator foramen. We'll be able to see the pelvic brim or the posterior wall better, and this is the roof of the acetabulum. So here, this is an example showing that this is a posterior wall of the acetabulum fracture, which is well seen in a operator view. Here again, we are able to differentiate whether the operator foramen is intact or not. This helps to differentiate between a T-shaped fracture and a transverse fracture. So another pathomorphic sign, the spur sign, it is also well seen in this particular view. It is nothing but it is a specific of a associated both column acetabulum fracture. It is caused by the medial translation of the distal part of the acetabulum, and the inferior part of the sciatic buttress, which is in contact with the axial skeleton, is seen as a spur there. So if you see a spur sign in an oblique view, it means that we are dealing with a associated both column fracture. So next is the iliac view. As we said, in this view, we will not be able to see anything about the operator foramen, and we will be seeing the entire iliac bone in profile. So this is taken with the same side of the hip. In the opposite side of the hip is raised. So we will be tracking hitting at the angle of 45 degrees. So the iliac oblique view and the operator oblique view forms a 90-90 orthogonal relationship to each other. So as we said, this since it is we will be able to trace the entire posterior part of the innominate bone. So this forms a sciatic, this forms the representative of the posterior column. Whenever there is a break here, it means that the posterior column is fractured. And the other thing which we will be able to better see is that since the anteversion of the acetabulum is negated, we will be able to see the anterior rim of the acetabulum here. So in an iliac view, we will be able to see any breach in the posterior column and anterior rim. Anterior rim and posterior column are better seen in a iliac oblique view. So here again, since the iliac bone is being seen in full profile, any fractures or any complexity of the iliac bone fracture can be well seen in this particular view. So then we form on to the classification of the fracture. So now Letournel classified this into a simple or elementary fracture types and associated fracture types. Again, the simple types is classified into anterior column, anterior wall, posterior column, and transverse fractures. And the associated fracture patterns are classified into anterior column fracture with a posterior hemitransverse T-shape, or a posterior column with a posterior wall, transverse with a posterior wall, and associated both column fracture. Without going into the details, what I would say was like once we see an X-ray, how to classify these fractures. It's all about how to read that X-ray and how to mark all those landmarks on a X-ray on a bone model. So here we can see that for example, in this site, we are able to first we are drawing the iliopectineal line. It is well seen there. Iliopectineal line is intact. So here again, we will be able to see that the iliopectineal line is disrupted. Here the ilioischial line is intact, but here the ilioischial line is also disturbed. So it is a both iliopectineal line and ilioischial line are disrupted, which means that there is both the columns are fractured, and we can mark all these marks. With respect to the all the other two views also, we will be able to mark those particular lines onto a pelvic model. We have to have a model in our hand, and we can mark all those lines. We can trace those lines, trace those points, and we can mark dots in the pelvic model. And once after seeing all these three views, here we have the AP view, this is the operator oblique view, and this is the iliac view. We can mark all those individual marking points on a pelvic model, and once we connect all those lines, we have a 3D orientation of that particular fracture with only an X-ray in our hand, and this will be able to plan our surgery better. And then we'll go on to the CT scan. Once we go to the CT scan, we'll get some more details. With that, we'll be able to find out what is a fracture pattern, and then we'll be able to better understand the fracture and do a surgery appropriately. With this, I thank the AOPAS and the Vidarbha Orthopedic Association and all the delegates for being a part of this webinar. Thank you.
Thank you very much, Dr. Sarvanan, for such a nice lecture. I now invite Dr. Makkar to proceed on how to read the CT scan, which is one of the most important investigations after X-ray in acetabular fractures. Dr. Makkar, can you share your screen, sir? Yes.
Is okay?
Yes.
Sure.
You need to share your screen. Your screen is not yet on.
Not
We can hear you, but your screen is not yet on.
Give me a moment. Give me a moment. Is it on now?
No.
Share?
Yeah. Yes. It is on now.
Okay. So I thank you, Dr. Sarvanan, for your beautiful talk, and you have made my life easy, and you have explained everything, and rather especially the dots that you have made. Now, my job is to tell you how I read the CT scans for the acetabulum fractures, and in this day and time, in fact, we have grown up using those duty views and all that, but of late, before making the decision of which approach to be taken, we need to have a CT and 3D views as well. So, I mean, these are the initial views, but I will be concentrating on the 2D axial. In fact, the CT basically is seen on the axial views only. Though we have sagittal views as well as the coronal views, but the main decision made on the axial CTs. So before coming to my topic, there's a thing that I want to tell you all. The Peterson et al. Carried out a comparative study between orthopedists in training and already graduated. Hoffman et al. Demonstrated there's a low agreement in the jury and internal classification among experienced evaluators such as residents. Now, in their study, 11% of the success occurred in the inexperienced group, and compared to the 61% of success in the group of hip surgery specialists. In the same study, it was observed that in adding computer tomography scans, there was an improvement in the success rate, with inexperienced professionals achieving 65% of success and experienced professionals 83% success. So this is a very important slide that we are going to show now. Axial view. Later to it is a wall fracture, and middle to the vertical line is a column fracture. We have to get us used to this thing at different levels to understand the CT scans. So what is the additional that we can get in the CT scans? We can find the loose bodies, we can see the comminution, we can see the marginal impaction as well as the head split. That is rather difficult to see in this routine X-rays. Now, Harris was the person who classified this CT-based classification, and he divided it into 4 parts. The type 0 is wall fracture, anterior or posterior, and type 1 is a single column fracture, anterior or posterior. Type 2 is 2 column fracture, superior or anterior and posterior, but he has divided into 4 parts where there is no extension. It is type A with superior extension, type B, inferior type C, and superior and inferior both type D. The third one is the floating acetabulum, where the articulation surface is detached from the axial skeleton, that we see in both column fractures in the routine X-rays. So, but I'm not going to go into details of these things because this will take another talk. I will be telling how I approach my patients so that I can understand that its geography, anatomy properly. So, as we see in the normal Jude views, first of all, is seen like this. In CT views, if we see at 3 different levels, coming from up to down, CT may look like this. These are small pictures. You will have to go time and again to understand these things at 3 different levels, how the CT will look at of this particular fracture. So here you can see posterior wall fracture. There's a combination with it. And next is the posterior wall fracture at the junction of the wall and column. Next is posterior column fracture. Jude view shows like this. And here, how can you see the CT scans? Anterior and posterior are marked. So this is the posterior part, posterior column fracture. There is a posterior column fracture at a different level. Now this is anterior wall fracture. This is the anterior wall fracture that we see in the Jude view. And this is how we see in the CT scan upper level, and this is the lower level. And we can see very well appreciate the communication as well. Now, anterior column fracture, in this case, as Sarvanan told, disruption of the iliopeteneal line is seen in the normal X-rays and the fracture of the ischioepigramus. In CT scans, again at different levels, from up and down, we can see different pictures like that. And we have to get ourselves used to it to appreciate at which level we are seeing. So here are a few pictures of it, at different levels, 1, 2, 3, and 4. Now the X-ray experience of the transverse fracture. So transverse fracture is that all 3 views over here, and this is how we can see in the bone model. This is again we see the 3 different levels. Now, one thing I want to say for the starters, we are very much baffled. How does this transverse fracture look like a vertical line, vertical split in the CT scan? Because when the model is rotated, if you can see this thing like this, so if you take a line layer like this, and CT scan will bring it like a vertical split. So here is a picture of it, a small line over this place, few more pictures of it at different levels, some more pictures, and I will concentrate on this one. We will see the vertical split over here. This is the transverse fracture, and now the next is posterior column and posterior wall fracture. This is the posterior column, as someone told you, and this is a wall. So in CT scan, how will it look like? It will look like this is the wall fracture, and this is the column fracture in axial view. Next is the transverse plus posterior wall fracture. All three Jude views and AP view. This is how it will look like in the bone model. Transverse with a posterior wall. And this is the vertical split and a posterior wall. Transverse and posterior wall. These are some more pictures of it. Split, vertical split, and a posterior wall. Now there's a T-shaped fracture. Here the obturator foramen is also broken other than the transverse fractures. So this is how it would look like in the bone model. This split and this split. Here is a axial view, and here we can very well see this transverse fracture and this split at the obturator foramen. So now this is a T fracture. Another picture of it. Now the associated anterior wall plus posterior hemitransverse. There is a slight difference between posterior hemitransverse and the both column, where we can see in the both column there is no attachment to the axial skeleton. So this is the normal AP and Jude views, and here we can at different level we can see associated part, because here the attachment is there. We can see very attachment at this part with the axial skeleton, and in the both we will not see that. Both column will not see that. This is not moving. Is there some problem? No. So these are the spur sign that we very well see in this Jude view. This is how it will look like. This there is no attachment with the axial skeleton. This is a similar part. Here we can see the split view. Here is how this will we see that the spur is formed in the axial skeleton. CT scan axial view. Thank you.
Thank you very much, Dr. Makkar sir, for such an excellent presentation. And now I invite Dr. Pradeep Kothadia from Solapur to speak on how to make decisions in pelviacetabular surgeries. Over to you, sir.
Where is that?
Screen sharing.
Yeah, I will screen share, but I opened it in my room. Can you just take next? I will just share the screen again. Just a minute.
Yeah.
Just a minute. Give me some time.
Yeah. So meantime, there was a question for Dr. Sarvanan. I'll ask that question for Dr. Sarvanan. So the question was, is there any case at all for doing Jude view? Because CT will show everything, and doing Jude view does put patient under some kind of discomfort. It was okay that we used to do Jude view in the past, but nowadays is there any view for this thing? So I think we can hold on to this question. Dr. Kothadia's screen is on, and we can take this question at the end of our first section.
Okay.
Good morning,
Sir,
everybody. Yeah.
Yes.
Yeah. You can talk, Pradeep.
Yeah, you're on, sir. I'm muting myself.
Yeah. Good morning, everybody. Now we have seen how we should read the X-ray and how you read the CT scan, come to what is the morphology of fracture. Now the next step is take a decision how to progress further. So there is always a debate whether we should conserve or to operate. So there is always a debate. All acetabular fractures which are congruent and stable, we can conserve but which are not stable, we have to operate. Why most of us would like to conserve? In good old days, when I was a resident, we never used to operate these fractures. No, why? What is the reason? Because there was a difficulty in understanding the three-dimensional anatomy of acetabulum. There was difficult to understand the columns so as to have classification. It's very difficult to understand the columns. It's difficult anatomy of the pelvis, and there are so much of vascular, neurovascular structures, and we are scared of that. That's why we are scared to operate on this, as the approaches are through this, and it is having a long learning curve. And the most important thing, we need a surgeon need a patient for this surgery. It's not putting a nail within 30 minutes or 20 minutes and come out of it. The impatient orthopedic surgeon should not take these fractures. To me, almost every acetabular fracture needs surgery, as this is an intra-articular fracture, and we know the principle of the intra-articular fractures, and they also remain the same as other intra-articular fractures like anatomic reduction, stable fixation, early mobilization, and why we need all these things to prevent degenerative arthritis of the joint, which is a very important. Hip joint is a very important joint for weight bearing. Now we'll see whether we can conserve this patient. Yes, we can conserve these patients. If I told you, if it is a stable and congruent femoral head under the weight bearing surface or dome of the acetabulum, which are stable, you can conserve these patients. Fractures having less than 2 millimeter displacement, you can conserve this patient, but they have to be stable. Roof up angle is a very good criteria to know whether the head in the acetabulum or it is in the very good position in the dome of the diaphragm. This is a roof up angle in all three views, and if it is more than 45 degrees, you can conserve these patients. And most important thing, if the patient is not fit for surgery, we can conserve this patient. I'll put on one example. Is an 80-year-old male patient with cardiac problems, with hypertension. Anybody would like to do surgery in this patient? No, it's very difficult to do surgery in this patient. 80-year age fracture, comorbidity with cardiac, hypertension, better not to operate. This is a bicolumn fractures. In bicolumn fractures, you can see the amount of comminution which is there. So I said we will do a total hip after total malunion of this fracture. This was the decision, and then we can give a one-stage procedure. So conserve these fractures, which is a bicolumn in old age with comorbidities. This is axial CT scan of these patients, coronal and sagittal CT scans showing very bad fractures. And see, this is the first X-ray. On your left side is the first X-ray. This is second X-ray on your right side, shows some sort of a good congruence of this acetabulum. This is after skeletal traction after 10 days. This you can definitely see the head which is centralized. Here see the head is lateralized, and see the acetabulum which is here congruent. You feel there is some congruent acetabulum. We call in the bicolumn fractures as a secondary congruence, so that you can get a very good, sometimes you get a surprisingly good movements of these patients. On 80 years, you don't need much requirement from the hip joint, so you can conserve these patients. What are the operative indications I told you? Unstable fractures, judged by the stress views in all three views or in the three views if the roof arc angle is less than 45 degree. Incongruent acetabulum fractures, displacement more than 2 millimeter, especially in the dome. Now, how we are going to treat the acetabular fractures? Now, how we are going to decide how we are going to treat these fractures? On which basis? You must know the morphology of fracture very well before taking any decision to treat these fractures. You should know what approach you are going to take, how reduction is going to do, how fixation is going to do, what is the post-operative protocol of this patient. Dear friends, plan of surgery is approach, special instruments, tips and tricks, fixation, post-operative protocol, and complications. But I am going to concentrate more on the approach today. What decision you are going to take, what approach you are going to take these fractures. Choice of approach, any of acetabular fracture depends upon the fracture type and the location of maximum displacement or combination, soft tissue conditions, and timing of surgery. The approaches most commonly used are posterior approaches. We are very well versed with these approaches. This is a posterior cochlear approach. It is either with or without subtrochanteric osteotomy. anterior approaches which usually are used is the ilioinguinal approach. Stopas, or nowadays we call it is the AIP, anterior intrapelvic approach, with or without lateral window, and iliofemoral approach. Now we'll see approach one by one. Extended iliofemoral, we'll see the approaches one by one. Cocker-Lung approach is a workhouse for the posterior acetabular injuries. The posterior tail approach is usually used when you've got a posterior acetabular injuries, you got a wall fracture or a column fractures. We must use a posterior approach. When you see this on your views, Judate views, as well as on CT scan, opt for a posterior approach in this patient. Posterior approach also can be done in cases of transverse fractures where the fractures are displaced more posteriorly. Here you can see this fracture, a transverse fracture. There is a fracture line which is going from here to here, and this is a fracture which is displaced more posteriorly and rotated most posteriorly. You can see this, and here you can definitely use a posterior approach to fix this fracture. Sometimes or many times you have to use a closed anterior column screw also in these patients. Posterior approach is used when it is associated. Transverse fracture is associated with a posterior wall. You can use this posterior approach because we have to fix a posterior wall also. We'll go to the now anterior approach. The posterior wall approach, we have this. We'll go to the anterior approach. Anterior approach, the gold standard when I was there, I was started doing it. The ilioinguinal approach was the gold standard approach for any anterior acetabular injuries. The anterior acetabular injuries are treated with an ilioinguinal approach, anterior wall and anterior column. These injuries needs a anterior approach, ilioinguinal approach. Nowadays, people, if the fracture is lateral to the iliopectoral eminence, they opt for iliofemoral approach also. This is also another anterior approach. Transverse fractures, which is displaced more anteriorly. You can see the anterior, there is the fracture. This is transverse fracture, which is displaced more anteriorly. You can see the more gap. And this is a posterior fracture line, which is there, which is a subtle fracture, which is a very crack fracture. You can treat this patient by using anteriorly ilioinguinal approach and fix one screw from anterior to posterior side in a posterior column. That is called as a minimal invasive surgery. See, this is a fracture which is opened out anteriorly. And this is a fixation of fracture by using anterior approach. And you can see this screw which is there, which is from anterior to posterior column screw, which is fixing this fracture. Okay. Then the second indication is anterior column with posterior hemitransverse also can be treated by using this approach. This is a case where there is an anterior comminution and there is a posterior, just a crack fracture which is there. This fracture can be treated by using an anterior ilioinguinal approach, but you have to put a screw always into the posterior column. You can see this fracture is fixed by using an anterior approach, and this is a column screw which is from anterior to posterior side. So anterior column with posterior. Ilioinguinal approach in bicolumn fractures can be used when there is a comminution or widely displaced anterior column with a posterior column which is a single piece or minimally displaced. We can use an ilioinguinal approach and fix this bad comminuted fracture which is there, bicolumn fractures. By using anterior approach, you can fix this fracture with a posterior. With this plate, I have put one screw into the posterior column and stabilize the posterior column. So this is a bicolumn fracture where you can use this ilioinguinal approach. Now, the next approach is a Stopa's approach. We call that is anterior intrapelvic approach, which is becoming more popular nowadays rather than ilioinguinal approach, because in ilioinguinal approach you are dealing with neurovascular structures, and there is limitations that you cannot expose the quadrilateral plate injuries. So this is a intrapelvic approach where you have to go into the pelvis and segregate. This is the ileum on your top, bladder and obturator vessels. You have to see everything, and then you will be on the inside, see the quadrilateral plate and dome impactions. So in quadrilateral plate injuries and dome impactions, this is a very good approach. You can see this is a dome impaction which is there. This dome impaction with quadrilateral plate injury with a medialization of the head has been tackled very well by this plate, and the dome is very well congruent in this patient. You can see very well the dome impaction has been tackled with this approach. Even Stopa's approach with lateral window can be used in bicolumn fractures with dome impaction. This is in bone infection is called the gill signs. This is a bicolumnar fractures, very badly displaced fracture. You can see this fracture is tackled by using anterior intrapelvic approach with a lateral extension of window, and this fracture is fixed very well. These are the incisions which is there for the stopage. Also, these fractures can be, you can use this approach for anterior column with posterior hemitransverse. Also, the beauty of this approach that you can put the plate intrapelvic also on the medial side, buttressing the column quadrilateral plate, which is a very good beauty of this approach. Even you can see the posterior column very well through this approach, and you can tackle the posterior column with a plate, with a screw, with this approach, which is an excellent approach, which is becoming more popular nowadays rather than ilioinguinal. Next approach is the iliofemoral approach, where I told you if the fractures are anterior column fractures are lateral to iliopectoral eminence, you can use this approach, which is a very good approach. You can tackle all the fractures through this single approach. So in this approach, you have to do a anterior superior iliac spine osteotomy is advised, because the inguinal ligament along with the sartorius muscles get relaxed, everything goes on to the medial side, and there are least chances of lateral cutaneous nerve of thigh injury during this iliofemoral approach. Combined approach, either in very complicated fractures, you have to use either extensile approach or combined approach. I am not used to do a lot of extensile approaches. I am used to do combined approach. I like to do combined approach in these patients. Either you can do a same setting or stage approach, but I always prefer to do both the things together in the same setting rather than doing a stage approach. There are definite advantages of it. Usually, ilioinguinal or AIP along with posteriorly Coker-Langham approach is done together. Stoppage with or without lateral window with Kale, as I told you. These are the approaches which I usually do it. Indications: badly displaced transverse fractures with or without posterior wall. Comminuted bicolumn fractures needs a combined approaches. Combined ilioinguinal and Kale approach for comminuted by. This is the case which is a badly comminuted anterior column as well as posterior column badly comminuted fracture, which I have tackled by using an anterior as well as posterior approach in this patient, getting a good result even at the end of 3 years. But these both approaches has to be in single setting. This is the anterior approach and this is the posterior approach. This is ilioinguinal approach with posterior approach, which is a Cocker approach. Extended iliofemoral approach is I am not used to this. This is a very extensile approach. It is usually indicated when severely comminuted bicolumn fractures also can be treated with this, and delayed fractures and malunited fractures. Now we'll see the approaches. Posterior wall, Coker-Langham, posterior column, Coker-Langham column, and anterior wall, anterior ilioinguinal. Classification, as I told you, all these fractures, pure transverse depends upon rotation, transtactal, anterior ilioinguinal, transverse posterior wall, Coker-Langham approach. T-shaped fractures. These are all the approaches which I told you enumerated is the same one. Now, dear friends, special situation has to be taken care that MIPO, ipsilateral neck femur, shaft femur needs a proper decisions to take. So decision taking acetabulum fractures, you have to define the fracture morphology. Conservative can be done or operative. Stays to be done. If they are stable and congruent, do conservative. Unstable, you go for operative. In operative, you open surgery or minimal invasive. Minimal invasive, percutaneous or semi-invasive. So approaches, as I told you, we have to categorize all the approaches accordingly, according to the fracture geometry, and take the decision to the take approach. Thank you. Thanks a lot. I finished.
Thank you very much, sir, for such a lovely presentation on decision making. So I would continue with the planning of acetabular fractures, pelvis and acetabular fractures. So so that's the place where I work. That's KM Hospital, Mumbai. So in this talk, we're going to see the preoperative preparation. We're going to see the table and positioning for the surgery. And then we're going to see the instrumentation and implants, and then we're going to see the backup instruments. So failing to plan is planning to fail. So acetabular fracture really need to be planned very well, as if it is your daughter's wedding. So that is the only simile that I can give you, that amount of extensive planning that is required for acetabular fractures. You know why? Because you are mentally prepared to fix this fracture. It saves a lot of time intraoperatively. A minute work preoperatively will save a minute intraoperatively. Sometimes a small fault in positioning can make a surgery a nightmare. So that's why you need to give position yourself. You need to think preoperatively. One missing instruments and again your entire surgery can go haywire. So lack of proper imaging intraoperatively again can spoil your day. So all these things are very important. And that's why you need to plan it very properly. And you need to do on the night before the surgery, you need to review the x-rays and CT scan, mark the fracture on the pelvic model, plan the steps in your head. So you need to do a virtual rehearsal of the surgery. You need to find out which are the steps where you require instruments, and whether the instruments are made available in autoclave. You need to make bowel preparation, because that will decrease your retraction effort and also will improve your visualization. Contour the plate on pelvic model before the surgery, that will save you a lot of time, and inspect the surgical site before the night of the surgery. So if you see this posterior wall fracture, if we can contour this plate on the model, or for that matter this anterior column, if we contour the plate before the surgery, it is going to save a lot of time intraoperative, especially you are not using those imported kind of plates with very good benders. So if you are using these Indian kind of plates with limited instrumentation, then you need to do everything preoperatively and don't leave anything for intraoperative things. So for the table, your table has to be radiolucent. You need to have free movement of the C-arm, and it should provide lateral tension. So generally I use this eccentrically loaded table, so that the table post is on one end. So we get an entire area below the table for free movement of the C-arm and imaging. And you want a table that can be tilted on both sides. So in case it require, you can tilt the table on either side, so that it will improve your ease during the surgery. There are special tables such as fracture tables, where you can put the patient in traction in supine and prone position. You can give flexion to the hip. We don't have this table available. I have no experience, just to tell that these are available. As far as positioning is concerned, we can give lateral position for KL approach or extended iliofemoral approach. So in that case, you need to check all the supports and side doors of the table. You need to check that they are not coming in way of imaging. In case you are planning supine position for anterior approach of the acetabulum or sacroiliac screw, then you should have the position of Trendelenburg position to move the abdominal content stapelad. Also, you should be able to have a contralateral table tilt so as to move the content and to improve the trajectory of your screws. In case you're planning a prone position for posterior injuries, then you need to have appropriate frames for which you want to keep the patient in prone position. A floppy lateral position, as Dr. Kothadia was saying, in a combined approaches, then in that case you need to have these clamps and support to the table, where you can fix the patient to the table. I use this rolling on position, where I can take that the support off, sterile support off, and I can turn the patient supine and prone in the same position. So in that case, appropriate planning needs to be done prior hand. Attachment to the table, so there are attachment to the table which can be fixed, and then instruments can be attached to that. I don't use it, but they are definitely there. Some people like to use it. Sometimes for fixing the pelvis fracture, you need to fix the patient to the pelvis. So you can use this shank spin and fix the patient to the pelvis, so that you can give effective traction. Again, I'm not very big fond of this particular type of contraption, but they are available. So as far as instruments and implant, use the instrument that you are comfortable with. Even a master with wrong set of instruments, he cannot do the job very well. So there are different kinds of instruments. You need to have retractors. So these are different kind of pelvic retractor. They are available in radiolucent manner as well. So we have malleable retractors, which are very useful for retracting the bladder. You can have obtuse vein to that retractor, and you can retract the bladder very efficiently. You can have sciatic nerve retractors in case you are planning the posterior approach. They do not cause pressure on the sciatic nerve because of their particular contouring and curves. So that's how we can retract the sciatic nerve. And then there are levers that can be used in anterior approach, which can use as a reduction device as well. You can have superior gluteal nerve retractors, which can be used sometimes when you want to work supra acetabular region. So there are different kind of superior gluteal nerve retractor available as well. So then coming to the reduction clamp, you have your king tongue acerbic clamp, which can be used for particular fixation, especially when you are doing by the iliofemoral or ilioinguinal approach. So in this manner, they can be used. There are multiple ways that these instruments can be used. You can have a symmetric king tongue clamp, which can again be used for oblique kind of fracture to compress this fracture. A symmetric clamp is very useful. Mata clamp, which are available in straight and in curved and in various sizes. They are very versatile instrument and very useful for acetabular surgeries. So you can use again in various morphologies and in various fracture patterns and in various manners you can use them. A Weber's tenaculum is especially useful through the middle window of the ilioinguinal or through the lateral window to fix the iliac crest. And a Farabeuf clamp to bring the fragment closer. They are screw-based clamp. And another versatile instrument is the Jungbooth clamp, which can really give movement in all 6 directions, and they are very useful in treatment transverse and posterior column fractures, and many of the time it will save your day. So they have movement in all 6 directions. So then you have manipulators. So direct manipulators such as picador. So they are ballpoint pushers. They can be used either in isolation or with the disc to push the fragment like that for anterior or posterior approach. You can use the interfragmentary jacking, where you can just put a curved instrument inside the fracture and turn it over and reduce the bayonation. So such instruments also can be available. So you can use a curved osteotome, or I can use a curve. I use generally a curved Steffi. Bending pliers are very useful for intraoperative contouring of the plate like that. And then you have in situ bending as well. So you need to have in situ benders, which again are very helpful. Coming to the implants, there are different kinds of implants that are available. So on the left side of the screen are the imported implant where there is a sinusoidal curved plate, and then we can have Indian implant as well, which are generally rectangular and cut off this thing. So it becomes little bit difficult to contour them. However, they can be used if you can contour them preoperatively. So you can use different kind of plates for the posterior injuries, and then you can use different kind of plate for anterior injuries. So different kind of plates can be used for anterior injuries also. So all this contouring can be done. So the the bottom 2 images, you can see that there are the buttress plates that are used. So generally the posterior buttress can be very well fashioned from 1/3 tubular plate. So if you can cut this 1/3 tubular plate in that manner, you can very well fashion a 1/3 tubular plate. So that cutters and everything has to be kept in ready on table. So if you are planning that, those instruments need to be planned. So this is the way a plate can be used. Or if you are planning a buttress plate, then using this buttress plates, the screws can come onto the acetabulum, and so I generally try to use obliquely bent plate. So such oblique benders, of course these are not the instrument that we are going to use in surgery, but oblique benders need to be kept in place so that your screw position can come in a safe zone, and you can very well buttress the plates. So backup instruments, there are Warbuch clamp, Jacob's clamp, long Cobb's elevator, and there are many more. So in case you have any problem, all this should be kept in a trolley. You should have good nibblers, good scoops, good long sleeves. There are a lot of instruments. So these all the instruments can be thought beforehand and need to be kept autoclaved in a separate trolley. So in case you need them, you can always use them in a fraction of a second. So take home message, we need to plan thoroughly. Discuss. So one night prior, you need to call your friends. So even today, we discuss among yourself. We get the case. I'll call Dr. Kothadia, I'll call Dr. Kale, and we'll discuss the case with them. So it takes a lot of mental work. It eases a lot of mental work during the surgery. And more you work pre-op, less you have to work intra-op. And every instrument has a role. Thank you. So that finishes our first section of the symposium, and then now we'll take on the questions for the first 4 talks before we go on to the next 2 sessions. So I'm unmuting all the faculties, and I'll take the questions which are there on the YouTube chat box. Yeah, so starting with Dr. Sarvanan. Dr. Sarvanan, we had a question to you before, which I asked. So I will repeat the question again. So is it really a role for this oblique view nowadays because CT scan is available? What is your opinion?
I would definitely feel that today, even today, there is a role because of 2 reasons. Intraoperatively, we don't have a CT scan to say that the reduction is perfect or not. unless and until we study preoperatively how this fracture is looking like in these oblique views, intraoperatively we will be able to find out, or we will to surely say that this fracture is anatomically reduced. This is number one reason. And the number two reason is that I strictly follow whatever my teacher, Dr. C.J. Thakkar, has told me. He said we'll have to do all those X-rays, and first thing I have to do is I have to spend 10 minutes with the X-ray and try to create a mental picture about that particular. We have to see all the three views and then create a mental picture among in our head, and then go into the CT scan. Because once we make a shortcut, once we start seeing the 3D CT directly, we'll be losing a lot of information. So that is another reason why even today I do this oblique views as well.
Yeah, the next question is, which is the ideal view for visualizing the superior dome impaction, both to Dr. Makkar and Dr. Sarvanan? Dr. Sarvanan first.
Yeah, see, actually the dome is well viewed in a AP view itself. You will be able to, but actually a dome, we don't see the exact dome in an X-ray. We just see the roof, which is, as I said in my presentation itself, whatever the sourcil or the roof which we say, it is just a thin rim or the cranial most part of it is only a part of the dome. We don't see the entire dome by per se. And number two, the operator view, we will give a better view of the roof of the roof or the dome region than an AP view. And again, once we go into the 3D CT scan, we'll be able to assess the dome better.
So I think the Sarvanan answer is already. In CT scan, we have got all the three views as well as the 3D views as well. The axial view, coronal view, and the sagittal view. This is also shows the extension of the fracture upwards and downwards as well in one view. And definitely the 3D construction that we have gives us a clear picture of how to approach the bloody dome.
So another question for Dr. Makkar is, what about 3D printing? 3D printing, do you do regularly? And if not regularly, what are your indications?
It's not available. I am in Lucknow. It's not available here. I've just had a talk with the Dr. Vaibhav Bhagaria when we were having a conference in Bangalore, AOPAS, and I invited the company to come to Lucknow, where I'm organizing cadaveric workshops, and I have organized almost 6 workshops over here in Lucknow. This year it will be the 7th one in November. So maybe this year we can invite him for the 3D construction, but people are not very much interested in going in because it's an added cost that it goes with it.
So I'll add on to it. From the level of imaging, the basic level of imaging is X-ray. The second level of imaging is the CT scan. And the third level of imaging is what I would say is the DICOM post-processing, where you can take the DICOM images, process it in your computer, make the model, subtract it, play with it. And I think that gives a lot of information to you. On the top of that comes the 3D printing, which in my practice is hardly 1 or 2% of the cases that I will do. They are available in Mumbai. We have worked on a cost. I can get it done as low as 7,000 to 8,000, but still it is just 1 to 2%, just to add to Dr. Makkar. So next question is to Dr. Kothadia. And the question is, sir, what are the indications for using trochanteric flip osteotomy in the KL approach?
When the dome is there, fracture is higher levels, the wall fracture is very higher levels, or it is a old fractures where you are dealing posterior column injuries. In these patients, you need a trochanteric flip osteotomy. So this is the indications. Wherever you want to see the upper portion from KL approach of the acetabulum, then you need a dome osteotomy. Number two, if you don't do a trochanteric flip osteotomy, you are with too much of retraction, you are likely to damage the superior gluteal vessels and nerves. Whenever you feel you are likely to damage the superior gluteal vessels and nerves, you do a dome osteotomy and it get absolutely relaxed, and you get a very beautiful view of the complete superior portion of the acetabulum.
Okay, so there are 2 questions which I want to combine, and both of them is for Dr. Kothadia, and of course others can also chip in. Number 1 question is there any role of lateral traction preoperatively while the patient is in waiting room? And the second is, suppose there is a 80-year-old man and which you think that is not an indication for surgery, would you give a lateral traction to that patient with respect to pin as a part of conservative treatment?
Nowadays, the lateral traction is not been given any time, because it has been seen many times when you give lateral traction, there are chances that the pin gets infected, and if the pin gets infected, then the further procedures becomes very difficult. Either a total hip or no reconstruct procedure becomes difficult. So when the patients are in the ward nowadays, nobody gives lateral traction. Lateral traction is absolutely can say has given up nowadays because of these problems. Anybody would like to add to it?
Yeah,
In case we are not planning to operate upon, then we can go for a traction.
No, we have
there's no
actually
need.
published about conservative management of acetabular fractures in the Journal of Trauma. In that, we have told that if we give longitudinal traction in abduction, there is a vector of lateral traction present. When in abduction, if we are giving the longitudinal traction, there is a vector of lateral traction present. So that is enough. Usually lateral traction, we are removing his chances of further total hip replacement if it gets infected. So putting a pin is not appropriate.
So another question, and that is for me, I think DICOM they say DICOM, that means they must be asking DICOM post processing. Can it be done anywhere, and how to get it? I think it can be done. There are multiple ways. If you can go on Google and search for DICOM post processing, you can get multiple talks on it. In fact, my own talk is there somewhere on the YouTube, and we'll definitely take one more webinar on just DICOM post processing from the AOPAS side, because it's a huge topic and we can definitely talk on that. One more question that is about the intra-pelvic plate bender. So do we have the intra-pelvic plate bender? So the intra-pelvic plate bender at present is available only with synthase. In situ bender, the twisters we are able to make, that we have, but the in situ lateral bender at present is available only with synthase. Dr. Nirbhay Karandikar, do you want to add anything? Our convener, hello.
He is on the chat box asking some questions.
You are not audible.
Yeah. So yes, Dr. Nirbhay Karandikar, you can ask. Hello.
Hello.
Yes.
Achha, I was telling about this plates that you're telling. Then in fact, Synthes, other than Synthes, there are a few companies as well. They are making good instrumentations.
Yeah. Yes.
And Miraculous and all that. And we are to cut the cost. We're using that as well.
Yeah. So Dr. Karandikar, your voice is not there. He want to ask that if the X-rays are to show what the Siam shows, then maybe surgeon should not be doing the surgery. Googly. Yes.
No.
I mean to say is that your CT is going to show you everything else. So why unnecessarily expose the patient to discomfort as well as extra radiation? If you are doing it just so that you are oriented to those X-rays during surgery, then perhaps there's something else that's missing there, isn't it? Maybe it is time to change a little bit. Just maybe.
But
yeah,
post-operatively,
I think
we do X-rays, isn't it? We do Jude views.
Yeah. Yes, post-operative is fine. Absolutely agree. Post-operative, because you want to make sure that your everything is in place, and you just is also for documentation. Post-op is absolutely essential, and most probably post-operatively, a lot of us are not doing post-op CTs. So post-op X-rays makes a lot of sense. But pre-op unnecessarily getting and whatever. Pradeep, go ahead.
Yeah. So I think this is a very important topic of discussion, and we are around 3 to 4 minutes left for this session question answer. So this on the same topic, I would like to have opinion of each faculty. So starting with Dr. Sarvanan, what do you think about this?
Yes,
do you really find a way? Do you really find any sense in doing it preoperatively once you are oriented, of course?
Yes, sir. Actually, what I would say is that when in the initial part of the learning, and it is really a standard protocol that once we know that this seminar is being attended by a lot of young surgeons. So for them, the message should be that they should take those X-rays and they should read those X-rays, and they should be able to assess how they will be able to see that X-ray. So the message is that for this, mainly for the younger surgeons. probably once we are experienced, probably once we do around 100 odd cases, we might see only with an X-ray of the AP view and with a CT scan, we'll be able to decide and plan. And it is not for experienced people by nearby. Probably this is mainly for the young surgeons who need to definitely assess all those, take those views, get enough information out of it, and then plan the surgery better.
So may I come in?
Yeah, Dr. Makkar, yes.
In fact, as for me, we are oldies. I started operating these cases some 23 years back. And that point of time, we were used to X-rays. That is one point. Second, Dr. Nirvay said, exposure to the radiation. One CT will take almost 50 times one X-ray. So if we are add up 1, 2, 3 more X-rays, the radiation problem should not be, I think, discussed. One thing. And of course, post-op, as Sarvanan said, we definitely are going to get the X-rays done. So we have to have a comparative study as well, and to keep in the records as well. Thank you.
Dr. Kale, yes.
See, whenever you are looking at these fractures, the protocol is you should follow the ladder step by step. You can't climb on to the 6th step without climbing the first 5 steps. If you are able to diagnose the fracture only on X-rays, that clearly shows your understanding of the fracture. So make it a point, make it a rule that you should see both the Judet view. They give you 98% of the information. The CT is done only to see the finer structures like impaction, the comminution, the intra-articular pieces. So if you are going to teach the students that directly do a CT, I think it's a wrong information. Every orthopedic surgeon should learn this by going through the X-rays first, then the CT, then the 3D CT.
Okay, so this brings the first session to an end, and we'll start to the second session of the webinar, that is management of specific fractures. And I now invite Dr. Lokesh to speak on the geriatric fractures, which are now exploding in numbers. As the Indian population is going towards more and more geriatric, we are going to see a lot of them. So Dr. Lokesh will get through. Meantime, I would appreciate if all the faculties can put their views on the YouTube chat box also. So you can start on chatting with the delegates on YouTube chat box also.
Good morning, everybody. Welcome on a Sunday morning. Welcome from Bangalore. And it's a good initiative to have a webinar during our lockdown period so that we continue to learn. So my topic for the day is geriatric acetabular fractures. So when we are learning about the basics of acetabular fractures, what is the point of coming into a concept of geriatric acetabular fractures is there is an explosion of geriatric acetabular fractures nowadays. More and more acetabular fractures are actually geriatric fractures. Okay, there is a 2.4-fold increase in the incidence of geriatric fractures, as it is seen in this article in JBGS American in 2015. There is a 2.4-fold increase, and the difference is 82% of young adult acetabular fractures are because of high energy trauma, and about 50% of fractures in the elderly is due to low energy trauma. It is usually just because of a fall. So we should understand that the pathology, the biomechanism of injury is totally different. How usually acetabulum fractures in most of the cases is a dashboard injury in a young adult, wherein the hip is in various degrees of flexion, extension, and adduction, abduction, causing various types of fractures. But the mechanism of injury in a geriatric most of the times is because of a fall on the side, the direct impact to the acetabulum through the greater trochanter, causing an antimedial force, fracturing and displacing the anterior column and the quadrilateral plate, which is seen in most of the cases. As we see in the further slides, almost 60 to 65% of the cases, there is fracture of the anterior column and the quadrilateral plate. And the femoral head medializes and the anterior column, and then the further migration of the head medially causes the GT to hit against the posterior wall and causes the fracture of the posterior superior wall. So these are the classic features of geriatric fractures as we see in this picture. One is the medial displacement of the femoral head, anterior column displacement, the quadrilateral plate involvement, and superior medial roof impaction. So this is the superior medial roof which is impacted by the head, and that's what is called a gull sign. Can we appreciate that? So next, what is the difference between the fracture patterns seen in a regular uh, young individual getting a fracture and a geriatric fracture is 26% of these fractures are associated both column fractures, 19% anterior column with posterior hemitransverse, and 19% are anterior column fractures. We see that only 0.4% of the fractures are posterior column fractures. That is to say, most of these are because of slip and fall on their sides, and the impaction causing fracture mostly of the anterior part of the pelvis. So we see that these three fractures constitute almost 65% of the total fractures. So these are the poor prognostic factors supposed to be, but we are actually some of the factors we are trying to get over, like the gull sign, which I mentioned, head impaction fracture, marginal impaction, hip dislocations, pre-existing osteoarthritis, femoral head and neck fractures, and posterior wall combination. This is also from the same article from JBJS American. 22% risk of conversion to THR is present at the end of 29 months. So non-operative is planned when we cannot manage it. We should only do of surgery when we are confident about getting a good reduction and adequate dome coverage. Otherwise, non-operative plan is done, and then we actually, once it is done, once the malunion happens at some point of time, we can do a total hip replacement. Operative management is mostly usually through an anterior approach, stopas, or an ilioinguinal approach. So over the years, so we have been doing ilioinguinal approach for almost 15 years now, but from the past 7 years, more and more of stopas approach is used for the reason that we can reach the quadrilateral plate directly and we can buttress from the inside. The attempt at reduction to be done only if the good reduction can be achieved. I want to reiterate that. So this is one of the injuries wherein there is typical medial migration of the femoral head. The anterior column line is broken. There is dome impaction here. So we use a lever through the Stopa's approach and we push the dome fragment back into place, and we use a infrapectineal intrapelvic plate. Usually there is also something called a raft screw which is put just directly over the dome of the acetabulum to hold the fragment back in place. This is another patient, 68-year-old female. There is again the same scenario wherein there is anterior fracture, the gull sign, and everything. This is the CT scan, which is showing the medial displacement of the quadrilateral plate. And we see this is typically like a trapdoor opening. The anterior part, the suprapectineal part displaces anteriorly, the quadrilateral plate displaces medially, and between the two, the femoral head opens. So in such scenario, we usually typically use an infrapectineal plate here and a suprapectineal plate here, and buttress. We push this fragment downwards, we push this fragment internally and externally, and that's how we do. We actually fix these fragments, and we use, actually was discussed, we use the Jude views to ascertain this. And this is the fragment I was mentioning. There is a posterior superior dome combination, and this can be held from the SOPA approach itself. Then another fracture, which is because of slip and fall in a 55-year-old man, and it's a bicolumnar fracture as is we seen here. And what we do, we actually use a iliofemoral approach and we use a Stopa approach. We combine the two approaches, and again we try to catch hold of the posterior superior wall fragment and also get a good congruent reduction as is seen, the head and the dome of the acetabulum being congruent to each other. Another patient with a 77-year-old male fall at home. There is again typically medial impaction and quadrilateral plate displacement. This is another typical fragment wherein there is almost isolated quadrilateral plate displacement. Anterior column is not at all displaced. So this is also seen more and more now with anterior column fractures. And this was those times when we were doing more of ilioinguinal approach for these. And what Dr. Pradip Nemade showed us beautifully how we twist the plate and bend it through the ilioinguinal approach. We use it to buttress this fragment. We push it backwards and we actually put screws here to push the quadrilateral plate back in place. So another 67-year-old male with a similar story to say, and that is where it is. So this is typical of a geriatric fracture. The anterior column displaced anteriorly, the quadrilateral plate displaced medially, and there is a window over there. And we have to put a suprapectineal and an infrapectineal plate to actually fix this fragment. And that's how it looks after we have fixed through the stopa and a lateral window. So another case, a 72-year-old patient, femorally fixed with a stopa approach. So total hip replacement is to be done acutely in some patients. Of course, it is better than total hip replacement for osteoarthritis because there is a fixation also required along with total hip replacement. But one specific article I want to mention is during the Journal of Orthopedic Trauma, which mentions that total hip replacement in geriatric population seems to fare better than ORIF. But we would, of course, as pelviacetabular surgeons, we would like to differ in our views on this, that whenever adequate fixation can be done with a stopa approach, we can actually get a good reduction and stable fixation. We should go for it. And total hip replacement is done whenever there are poor prognostic factors, as was mentioned previously. So in summary, geriatric fractures mostly involve the anterior column and the quadrilateral plate. The reduction of the dome impaction is critical for a good long-term outcome, and quadrilateral plate is best fixed by the infrapectineal plate through the Stopa's approach. Thank you very much for your patient listening.
Thank you, Dr. Lokesh.
Thank you.
Thank you, Dr. Lokesh. Now I invite Dr. Dinesh Kale sir to speak on the tips and tricks to reduce posterior lip and posterior column.
I'm not able to move my slides.
Click on the PowerPoint, sir, and then move. Yeah.
Okay. Good morning to everybody. This is a place where I work in a small city called Belgaum in Karnataka. Now I'll be talking on tips and tricks of reduction of the posterior wall and posterior column. The previous speakers have already told about the instruments, the X-rays and everything. But small things that I would like you to bear in mind is, whenever you are starting a case for the posterior column and posterior wall, make a full assessment of the morphology of the fracture. Draw a neat diagram either on a plastic model that you have. Draw the various fracture lines, note down the number of pieces that are there as seen on the CT, and then proceed ahead with the surgery. Because at the end of the surgical procedure on table, you should be able to correlate the pieces that you have taken out. Be aware of the associated fracture with the posterior wall or the posterior column in the form of transverse fractures, T-type fractures, both column fractures. Now it is the surgeon's choice, the comfort and the training that he has received, whether you would like to use a prone position or whether you would like to use a lateral position. Both have their advantages and disadvantages. The advantage of the prone position is the visualization of your trajectory of all the screws is excellent in a prone position. But look at the position that you are putting the patient on. It's quite an uncomfortable position to place the patient on the tables that we have. The lateral position is the position that we are all accustomed to, but C-arm visualization is very, very difficult in a lateral position. First and foremost is you should have a wide exposure. Please do not compromise on the exposure. You should incise the G-max tendon. Otherwise, your exposure will not be wide. You should visualize the sciatic nerve, but do not dissect the sciatic nerve. It is not necessary to dissect the sciatic nerve unless pre-operatively you have noted that the patient has got a palsy. Then it becomes mandatory for you to dissect the full course of the nerve. You must tag all the tendons. We are used to doing either a bipolar or THR where we take one single incision from the posterior part of trochanter where we elevate the capsule and the rotators. Here, every attempt should be made to dissect between the tendons and the capsule. Remember, the obturator tendon is the strongest tendon by which you can really pull the pelvis. And if you properly tag this tendon and pull it towards the surgeon, it totally covers the sciatic nerve. And then you start dissecting under that. At no cost should you cut the quadratus. Now, the wall fractures identification should be done without the soft tissue detachment, and the best instrument to handle this is your fingers. On the left side, you will see here, I am lifting the wall fragment. All the soft tissue here remains attached here, and then you should start working under that to remove all the debris. The best instrument to remove the debris is a disc forceps. It is the least traumatizing. Now, what do you mean by a impaction, the wall impaction? Normally, when you open the acetabulum, this white glistening wall should never look at you. It should be covering the head. If you see such a picture, take it into consideration that this patient has got a impaction. Now, how do you disimpact this? You'll have to use a long, sharp periosteal elevator and template this back onto the head, because your head is the templating surface on which you are going to recover the wall. Once you have covered this, you will get a void here. This is the area that you will need to bone graft. Now, when you come to the closure of the impacted wall, you will need to hold it temporarily and then start primary stabilizing some procedure in the form of K-wires and then the screw fixation. The best instrument that you can use here is a ball spike. With a ball spike, and it is better that you yourself hold the ball spike till the stage that you are going to use the K-wire, because sometimes the assistant does not know at what pressure he has to hold the ball spike. Now, this picture shows that you have completely covered the deflected wall piece over the head. How do you pass the K-wires? Now, whenever you are passing the K-wire, the first few millimeters of entry point should be absolutely vertical to the bone, and then angle your drilling instrument in such a way that you are pointing it to this surface, that is the sciatic notch surface. You cannot afford to enter from here inside the acetabulum. I always prefer to use K-wires instead of drill bits, because the K-wire creates a cylindrical passage. A drill bit cuts through the cancellous bone. Now, if you are going to use a 2.7 screw, better drill it with a 2 mm K-wire, so that these screws are going to cut their own threads into a soft cancellous bone. Now, this is how you fix the wall with your K-wires. Now, there are two ways of fixing this. If you have a bigger wall piece, distance this fixation in such a way that your final trajectory of screws will come in between the two wires. However, there are sometimes conditions where you may require to pass the screw in the same trajectory where you have fixed the K-wire. Then you will have to do it in sequential fashion. Remove one K-wire with a ball spike, keep the wall pushed, pass a screw in that, then remove the second K-wire, again keep the wall pushed by a ball spike, because on one screw the whole thing can rotate. This is the way that you pass the interfrag screws. Remember, on the table you should have very small screws. I normally don't use 3.5 screws. I use 2 mm or 2.7 mm screws. This is a picture that shows that the wall has been fixed. Now, coming to the column, should you fix the column first or should you fix the wall first? As a rule, it is always the column first and then the wall, because an open wall piece is beneficial for you to visualize the reduction. Is there a condition where you can fix the wall first and then the column? Yes. If the wall piece is not coming in the fracture line of the column, you may opt to put the wall piece. But as a general rule, remember, first column, then wall. Now, these are some reduction maneuvers that you are going to do. The first is the use of shunt spin. Everybody knows how to use this shunt spin. What I would like to highlight here is, do not put the shunt spin in the area where you are going to plan to put your last screw of the plate. Otherwise, that hole becomes very big. So remain slightly eccentric so that it does not hamper your screw of the plate. Then you can derotate this. While you are derotating this, your one finger should be inside the sciatic notch to also see the reduction from that side. Dr. Pradeep has already told you about these instruments. You can use a Weber clamp as seen here. You can use a Youngboth clamp. Remember, again, in the use of these clamps, the screw holes, if you are going to use the screw holes as the same screw for the plate fixation, then one screw can come in that place, the other screw has to be away. If you put it in such a way that the screws come in the way of your plate, then you will find it difficult to remove this and put a plate. Now, this is the final buttressing of the wall piece that you have fixed. Remember, in a wall fracture, your plate should cover the wall with no screws on the wall. Your final picture should look something like this. How do you know whether your purchase is good? The last screw in the ischium should be as long as between 55 to 70. If that is the length you have, be sure that your fixation is good. If you are getting something like 30, 35, please go back and look at the images. It gives you a feeling that your purchase is not good and you can't afford to pass one screw. There have to be two screws. Remember that the inferior most part of the ischium is very easily visible. However, the superior most part is very, very difficult to visualize. Then comes the position, then comes the use of traction. Now, if you are on a fracture table, it's very easy to distract. You have an assistant who's going to, the unwashed assistant can move the distraction unit and you can very well see the distraction. However, if you are taken a a lateral position, then you will require two assistants, one who is going to give a longitudinal traction and the other person who you will have to put a shunt spin in the neck and pull it. Now, if you have a person, somebody who is 100, 102 kilos, this becomes a problem. Now, this piece, as you see here, is a small cartilage flap. Again, it needs to be removed. Are there any other aids that you can use during this surgery? Yes, if you have an old fracture, you have opened the fracture, and then you see my pointer will show you a fracture line here in the anterior aspect. Now, if this is overriding, manually it is impossible to give any traction and distract this. You will have to use a external fixator. You will have to use a femoral distractor. One pin goes in the supraacetabular area, the other pin goes in the lesser trochanteric area, and then you start distracting it. It's an excellent device to give you on-table distraction. Now, when you have seen the anterior column, you can pass from the posterior and anterior column screw. When do you do a GT osteotomy? Dr. Pradeep Kothadia has already told you, but remember, it should be an osteotomy which starts from the uppermost area of the vastus lateralis going right up. Thank you.
Thank you very much, Dr. Kale sir. Hello. Yeah. I now invite Dr. Ashok Gavaskar from Chennai to speak on the anterior wall and column fractures.
Thanks, Pradeep, and thanks guys for joining us on this Sunday. I'll just give you a brief overview of how to deal with anterior column and wall fractures. If you look at anterior acetabular fractures, you have two elementary patterns, anterior wall and the anterior column. And then you also have this one, the anterior column and the posterior hemitransverse fracture. This, even though it has a posterior component, is grouped under the anterior column fracture for definite reason, and I will tell you later. Anterior wall fractures are very rare, probably rarest among all acetabular fractures. They can be associated with instability and dislocation of the femoral head, but not to the same extent as you see in posterior wall fractures. You have to remember there are two types of anterior wall fractures. One you see on the left side is the classic description by Letournel, where the anterior wall is fractured as a segmental portion of the anterior column. This is quite rare. What is relatively more common is the one that you see on the right, described as atypical anterior wall fracture that were described much later. In this fracture pattern, you have varying degrees of fractures in the anterosuperior rim. You have the head dislocated often. You may have varying degrees of impaction as well. And the thing that you need to note is that these fractures do not extend up to the pelvic brim. That is, the anterior column is left intact. If you come to anterior column fracture, there are different types. As you might know, the anterior column extends from as high as the anterior half of the iliac crest to right down below, where it extends up to the anterior half of the ischiopubis ramus. So you can have different fracture patterns depending on location. If you have very low fractures where you have the fracture exiting through the anterior wall, till you can have high fractures that extend as high as to the anterior half of the iliac crest. In very low fractures, most of the posterior superior weight-bearing dome is left intact. So if you do not have a dislocation or a great deal of displacement, these fractures can be conserved. In low and intermediate fractures, the amount of displacement is often minimal. The head doesn't get dislocated, but it often or always follows the fractured anterior column fragment. In high anterior column fractures, there is varying degrees of dome involvement. So these fractures are extremely critical. You need to get a proper reduction. You cannot leave a step off or a gap because it will lead to high contract forces and which can degenerate the hip in no time. So if you go by these recommendations, if you have low fractures, if they are not too displaced, they can go ahead and do well with non-surgical treatment. If you have high fractures, they often require surgical treatment for optimizing outcomes. The third fracture is the anterior wall or column with posterior hemitransverse component. This is essentially an anterior column fracture. If you look at the CT scan on the right, you can see the head following the anterior column, and the posterior hemitransverse component is low, which is often undisplaced or minimally displaced. What the posterior transverse component does is it allows the anterior column to rotate much more externally than what you would see in a typical anterior column fracture. So the amount of displacement that you see in these fracture patterns are much more than a typical anterior column fracture. This fracture pattern is more common in the elderly patient, where you can see these fractures with varying degrees of dome impaction. As a surgeon, the most important thing to appreciate in these fractures is that the majority of the thrust is anterior. So if you think you can do this fracture from the posterior approach, you will go terribly wrong. So how do you treat these fractures? Some of these fractures can be treated conservatively. I think Dr. Pradeep Kothadia already told you when to opt for conservative treatment. So I would straight away go to indications and how you do operative treatment. Open reduction is the mainstay for these fractures, which you can perform through various anterior-based surgical approaches. But select fractures you can do percutaneous or MIS techniques as well. These would be low anterior column fractures, which are essentially undisplaced, both in the young and the elderly, because if you want to get them back on feet as early as possible. And also in elderly patients, when you have non-reconstructible fracture patterns, where you can do these fixations as a bone stock procedure. So you do not worry about reductions. You get the columns fixed and then get a total hip done as early as possible. The need for primary total hip arthroplasty is extremely low. It can be considered in select fracture patterns when you have extensive comminution, impaction, or associated femoral head damage. So for this talk, I would restrict myself to ORIF predominantly. What are the surgical approaches that you can opt for? Unlike posterior fractures where you do not think beyond the carpal Langenbeck approach, there are a lot of different ways where you can approach these anterior fractures. In terms of exposure, probably ilioinguinal will give you the best, more exhaustive. It is still the workhorse approach for dealing with anterior column and wall fractures. The only limitation would be to would be limited access to the quadrilateral plate, but you can offset that by using an extended medial window. Iliofemoral approach is an external approach when you have an eye anterior column fracture superior to the iliopectineal eminence. Then you have the intrapelvic extraperitoneal approaches that would be stopa and the pararectus. The pararectus gives you a little bit more exposure compared to the AIP, but the AIP is more popular in terms of its versatility because it is more away from all the dangerous structures, and you can get the same amount of exposure if you can combine it with a lateral window. Already Dr. Pradip went quite extensively into the approaches. I'll just give you a brief insight into this. Ilioinguinal approach is still the most commonly used approach for dealing with these fractures. This would be a typical setup of how you do an ilioinguinal. Patient supine, you have something under the knee to flex the hip. You have a pin going up into the femoral neck to apply lateral traction. You have a Shams pin on the iliac wing to derotate the anterior column. The approach is done by using 3 windows, the lateral window, which is lateral to the post psoas major, which gives you access to the innominate fossa. The middle window is what you do majority of your articular work from. It gives you access to the quadrilateral plate and also to the posterior column if the fracture pattern necessitates reduction of the posterior column. The medial window or the third window is medial to the neurovascular bundle. A case example, a 39-year-old male who met with a motor vehicle accident has got an intermediate type anterior column fracture with displacement medially. If you want to do this through an ilioinguinal approach, this is how we used to do it some time ago. There is no direct access to the quadrilateral plate, so this is how we reduce and stabilize the quadrilateral plate by using a strong spring plate, in this case a 4.5 millimeter robust contoured DCP. So as you can see at 5 years, the reduction is maintained, the patient had a pretty good outcome. This is another case, an anterior column with a posterior hemitransverse fracture with bone impaction in a slightly older female. If you do this through an ilioinguinal approach, this is how you do it. You use an extended medial window so that you can get an infrapectineal plate as well. You can disimpact the dome through the second window and then support it with a wrap screw from outside. And for the posterior column, you can use an indirect reduction and then fixation of the posterior column screw from anteriorly. The iliofemoral approach, it gives you a sort of an extended lateral window-like appearance by virtue of an ASIS osteotomy. You can deal with fractures that extend from the SI joint till the pectineal eminence, so you cannot use it for lower anterior column fractures. If you extend it distally through the Smith-Peterson interval or the Uterus interval, it gives you good articular exposure as well, which might be valuable when you are dealing with articular impaction and femoral head fractures. A case example of a 42-year-old male with an ACPHT type fracture, you can see that you have the majority of the fracture patterns beyond proximal to the iliopectineal eminence, though it has an extension distally as well. There is a PHT component as well. So this was what done, an ASIS osteotomy, iliofemoral approach, a magic screw and a posterior column screw stabilized all components. And this is what it looks like at 2 years, preserved joint space and preserved function as well. The iliofemoral approach is very useful for dealing with atypical anterior wall fractures. This is an 38-year-old female with an atypical anterior wall fracture with instability. Patient's got a dislocated head and anterior wall impaction as well. So if you can do this through an anterior iliofemoral approach with an ASIS osteotomy, you get access to the articular surface. You can disimpact the joint, graft it if required, buttress them with wrap screws, and then a small mini fragment plate to buttress the wall fragment. The third one, which I probably prefer, is the anterior intrapelvic approach. It gives you a great access to the quadrilateral plate, allows you to buttress plate it. You can also combine it with a lateral window if you're dealing with eye anterior column fractures or you want to put a posterior column screw. Again, as with other anterior approaches, there is no joint exposure. There is no true joint exposure. In fact, you can access the articular dome. You can disimpact and graft it through the fracture planes, but there is no true articular exposure. Risks would be like injury to the corona mortis, obturator nerve, and the external iliac vessels. The most notable injury is possibility of injury to the obturator nerve, which has been described in about 25% of these patients who undergo an AIP. A case example of a 76-year-old male with an ACPHT type-like fracture, again did through a AIP with 2 plates and another plate to buttress the quadrilateral plate and also a raft screw from that plate to buttress the disimpacted toe. And this is what it looks like at 15 months. And if you have a posterior column component, if through these fractures, you can stabilize them with an additional lateral window to put a posterior column screw. And if your posterior column component is too low, you can also opt for a retrograde posterior column screw, which can be done percutaneously. So if you look at long-term results of anterior acetabular fractures, they are not bad, especially when you talk about anterior column and ACPHT type fractures. But what is bad is anterior wall fractures. The results with these fractures are quite poor because they are rare one, and it is difficult to access them, and you do not have a true joint exposure to know whether you have anatomically reduced them. So if you can get a good reduction in these fractures, these patients tend to do pretty well. In summary, anterior acetabular fractures are relatively less common compared to posterior types, but we are seeing them more common with the elderly population. Outcomes are pretty good with ORIF. If reduction is good, select fractures can be opted for non-operative or percutaneous fixation as well. Different approaches can be used. Most of them do not give you great articular access. These can be combined or extended as well. The need for primary arthroplasty is quite rare in our hands. Thank you.
Thank you very much, Ashok. Now one of the most important talk is how to prevent and manage the complication of acetabular fracture. And I would invite Dr. Dhaval Desai to take us through this important topic.
So we heard all the good things. Now my job is to make you a little worried. If you manage acetabular fractures over a longer duration, you will realize that complications are part and parcel of the game, and it's how you manage or tackle them will mature you as a surgeon. And it is your journey of experience of acetabular surgery that, management of complications. But they're there to manage. So this case, if you see, this is, again, the other thing is it affects younger patients very often. And very often the answer is not always total hip. So if this is a 20-year-old, 3 months post-op, painful, and you see that the joint space superiorly is reduced, there's widening of medial space, and there is trouble, okay. Sometimes the answers are possible, sometimes the answers are not possible. All right. So we heard different fractures from the speakers. So we had this 75-year-old. What is old? No, this guy is not old. He was crossing the highway. He's reasonably fit, family says. One kid from abroad. So he was to be operated in 2 days for an anterior wall column fracture with dome impaction. And the Sunday night, he desaturated, and he was referred for suspected thromboembolism. So he was now anticoagulated. Okay, so we continue with the story with this. Sometimes it's like a slippery slope. That the journey of complications can be one cascade effect. And I think it's where you enter and how you tackle. And I think it's also important to take right decisions at the right time with management of complications, I've realized. Okay. Right. So I think there are a lot of complications, acetabular fractures. I think it's how you evaluate, assess, and how you then plan management that's most important. I think it's important to know, how can you avoid them? Some you can with experience. Some you just have to, just have to weather the storm. But it's also important to counsel patients with acetabular fractures well in advance before, for surgery, that they are aware of potential problems. Because, if you tell them, it's there, it's somewhere stuck in their mind, and they always remember. Okay. And I think it's always, I think as acetabular surgeons don't like complication, but it is something that we have to believe that it's inevitable. It's also unavoidable as you do bigger number of acetabular, because there are some things not in your hand. I think it's a part of your learning process journey. Everybody of my colleagues who have talked have had their fair share of complications. And I think sometimes you realize that it's I did my best, and the outcome sometimes cannot, it's not in my hands. And sometimes patients will do better even after having problems. Okay. So we can divide them into early and late complications. And in the early complication, remember that patients can die of acetabular fractures. It's not that patients die of pelvic fractures, but patients can also die of acetabular fractures. I think vascular and neurovascular complications are something that are there because the fractures involve areas that are not easily visible and accessible. Neural and vascular structures are part and parcel of the game. And as a surgeon, I think it's important that you try and avoid, getting a mal reduction and getting implants that are encroaching into joint. This is as in your hands as a surgeon. And then thromboembolism with acetabular fracture is something that exists. We think that it is not there, but it is there. I will share with some examples, right? And then in delayed complication, everybody knows that why we fix articular fracture is to avoid late arthrosis, but particularly for acetabular fractures is the risk of heterotropic ossification. And then infection remains always a ever-present danger in any surgery, particularly sometimes in acetabular because it's hidden. You don't see the obvious signs sometimes. Okay. What are the risks? I think there are some fractures that have a propensity or prone to get complications. I think it's due with the kind of velocity of trauma, what it does to the other things. And then patients with their age, patients with their osteoporosis, patients with their, sometimes also the patients come delayed. So delay in presentation is one of the risk factors in having higher risk of complications. And finally, accept and don't be honest with yourself that you as a surgeon has to have, you have a learning curve. So as you evolve, there in the early stage, there will be more complications than any if you need to mature faster to have lesser amount of complications. So some fractures you will know beforehand. This is going to be a bumpy ride. It's not going to be an easy journey. So this is a transverse acetabular fracture associated with the comminuted shaft femur intertrochanteric fracture. The femur was compound. The anterior wound of the acetabulum, and what you must tell these patients with that this is not we on one operation. This may be 3, this may be 4, sometimes 5. So this patient had bone grafting, he had stage reconstruction, and then finally he developed eventually came up with knee stiffness, right? So eventually came for arthrolysis of the knee. Hip is another area in the long run that also eventually deteriorated. So it's many things that can go into patient's life, right? That patient, which we said was thromboembolized, next day deteriorated, became unconscious, large intracerebral bleed. So second day or third day, he was referred from periphery. So now he has a 75-year-old now needing a burr hole, evacuate a large hematoma. What can you do as a surgeon? I went in and put in a stymine pin because I wasn't sure where I'm going to now get into this fracture, around that. Again, wondering now what to do, whether to give up, whether we continue. At 1 week patient, and we think that, 75 may not improve. So at 70, this guy was extubated at 8 or 10 days. And then he decided, he wants to go back to his parent hospital from where he came back. Okay, so the journey will continue with this. Okay, right. I think some fractures have a severity of traumas around that. So if you see a fracture, this is X-ray the first go, you have 2 problems in your hand. You have a bad hip fracture, you have a bad acetabular fracture. And then you must think about that. Okay, if the head's gone in there, the sciatic nerve is at risk, the head's at risk, the fixation is at risk, and then this will be a mega surgery, so you're likely to get infection. And then finally, in all but last, you're likely to get arthritis. Okay. This patient this was a young patient. Eventually, his hip deteriorated on that. Finally, he ended up at having a THR. So again, complication journey can be related to the severity of trauma. Question for my colleagues. I've seen this a few more times than one to be now aware of this. So patient, you're going to operate for somebody, patient anesthetized, given position, patient deteriorated. Okay. Patient now resuscitated, anesthetist said, sir, sab theek hai. So are you going to continue with this case or are you going to postpone this? I'm going to ask you this, your opinion at the end of the talk. Okay. DVT exists. If you look for, it's there. It's often subclinical because it's in the proximal veins. It's sometimes very difficult to get on the routine screening. I think you have to accept that some form of prophylaxis you need to take care of. And then when you have a pre-existing DVT with an untreated acetabular fracture, then your situation becomes complex. I think we can discuss at the end. Okay. Injuries to nerve, particularly sciatic nerve, I think is a part and parcel. One third in some fractures, especially posterior wall and transverse with posterior wall, especially with dislocations. But I think you as a surgeon can also cause acetabular sciatic nerve injuries. And as seen by colleagues, I think it's important to position, so avoiding tension on the nerve in prone positions. And then your retractors itself needs to be carefully planned. But with the newer anterior approaches that are being used, remember that femoral nerve and obturator nerve are also at risk because you are now putting retractors and entering into spaces and area, and you're retracting structures to get vision from from a different angle. So I think these are things that are there. The good thing about sciatic nerve dysfunction is there is a good potential for functional recovery. But again, one third would recover at least to and very often they are partial. Okay. Again, important to very well document that, if especially in a situation of polytrauma, sometimes in the middle of things you've forgotten, you've not seen that, there's other thing, they are leg fractures, so you cannot, and then pre or post-op, I think, therefore, I think it's proper documentation is very important. I think most of the times it's expectant. Most of the time it's bracing with physical therapy, and we expect that the recovery can take a long time, up to 2.5 years. Okay. Vascular injury is our dreaded nightmare. Okay. Everybody, all acetabular surgeons has this back in their mind, this nightmare that what if a superior gluteal nerve ruptures on table? This can be pretty catastrophic, and this is something that one must anticipate or one must try to avoid. But on the day where it happens, then you really have a job on your hands. With anterior exposure, there are other vessels, particularly the corona mortis. I think your screws, which you're passing in, and the anterior column can also hit the vessels around. And then rarely, sometimes you see anterior wall fragments that are stuck at the back of the femoral vein in the artery, and 1 or 2 times you have to really tease them out with around it. So I think there are fracture situations. I think it's important to, and then late thrombosis also is part and parcel of the game. I think it's important to identify early and explore and repair around that. Okay. Some fracture patterns. So fracture patterns that are going high into the sciatic notch, the posterior wall fracture that goes high. This is a fracture that you must almost think, or you must always keep, that the superior gluteal nerve is there somewhere. I've seen one fracture pattern where the superior gluteal nerve was between these fracture patterns. And then, if I thought there was a dilemma between going front and back, and if I'd gone front, I might have crammed the superior gluteal nerve. Okay. And some people would say that in high spikes, some would nibble off this bigger spike instead of getting the superior gluteal nerve around it, and then it's easier to then move the superior gluteal nerve and the vessel. Sorry. Okay. With the anterior approaches, I think you're doing a lot of retraction. So we know about the corona, but you also beware that retractors will pay a lot of tension on the femoral vessels, and I think it's important to relax the hip consciously with flexion at least up to 40 degrees or 50 degrees, and giving time for taking off the retractors time in the middle, so to avoid that. Remember that the obturator artery also can be injured, because then when you're working inside the pelvis to the anterior and the posterior column, then you'll be putting in retractors there. Okay. Infections, depending on what or how your experience, infections can be up to almost 10%. Pre-existing conditions of soft tissue hematomas and particularly the moral level lesions. I think it's important to avoid devitalization. And then I think when you see infections, treat them aggressively, because otherwise, if you sit on it, then it's catastrophic. Okay. So this was a very young guy, 25, posterior wall column infections at about 10 days. He also had a chip off of his posterior articular cartilage. So there was a bare area. Went in aggressively, washed it out as soon as we suspected this, covered with antibiotics. This is him at about 3 years. He's getting arthritic, but he's okay. He's hanging on there, and he's at reasonable function. So I think message is that treat very aggressively when you suspect or see infection. Don't sit on it. Okay. Intra-articular hardware is something that every acetabular surgeon consciously, I think, is aware, and something that one almost must check it out by use of multiplane imaging, especially in areas where it's dangerous. So anterior column screws and screws in when you're putting it around the dome in the anterior approaches, or even in posterior approaches when you're putting articular pieces. Then I think one must make sure that there are no intra-articular hardware. The best time to take it out is when you're there, and then post-operative CT whenever in doubt. A lot of us are doing post-operative CT as a routine. But this is something that needs to be avoided. And I think if you see it, I think it needs revision. Okay. Posterior column, the buttress or the marginal plate sometimes can be make sure that they are not lying on the articular head. Okay. Trochanteric osteotomy we heard. Remember that trochanteric osteotomy has a fair share of complications. I think one needs to balance the indication for using this. Okay. Mal reduction is something that the inexperienced surgeon, but even with the experienced surgeon in complex fracture, this one everybody consciously thinks that have I reduced this fracture very well? Because some of the times you don't see it. And the best time when one can, even in first 3 weeks, you can only get about 50% of good, better outcome with tackling it out. But remember, I think if you have a mal reduction, one must not be shy to refer it to somebody you think you can do a better job than you. So I think for a younger surgeon, this is always remember. Don't be shy to remember if you can't reduce the fracture. Don't sit on it. Okay. And then failure of fixations can be due with patients are non-compliant, bones are not holding. Sometimes the fixation is not adequate. But when you get failed fixations, always to think about late infections. Okay. And some failed fixation so it is again very difficult to salvage. You are situations where it's surgery is delayed, tissues are ossified, and then very often even arthroplasty can be a challenge. Okay. Sometimes the hip goes, I think. Okay. It's very rarely early, but it can also go in a delayed times. So again, MRI can be difficult here. Seen this in a couple of times that posterior, this typically with posterior wall, head, everything reduced well, okay? And then the hip just goes at 3 months. Okay, just gone, head is gone. Treatment obviously remains there in this situation, an arthroplasty. Heterotropic ossification is something that is there, especially with posterior approaches, very rarely seen in the anterior approaches. I think the injury to abductor musculature, and it's more to do with more extensile approach, the risks are higher. Use of indomethacin can be helpful as some people also do radiotherapy. The incidence may vary, is ruled very often, but I think it's also important to discuss with the patient. Does the patient have a problem with the HO? Okay. So this was one of our young patients, polytrauma. He went on ventilator, came out 1.5 to 2 months, went on to all his fractures healed. This was his heterotopic ossification. Do you want to take it out or leave it? Okay. Again, this is a question for discussion. Right. Late arthritis, I think, is part and parcel. Patients with acetabular fractures will get arthritis sometimes, or very often they say a decade earlier. The causes are known, but even in longitudinal series, 1/3 of the patients, there's no reason. You could not find out reason why this got late arthritis. Okay. You need reconstructions. You need now things about 3D printing and imaging. This is helpful tools when you're doing rate instruction because the anatomy and geography is changed, and newer arthroplasty solutions help you in tackling this. Okay. So this old guy, so he was 20. So now at 3 weeks, he settled. Everything was fine. Family keen to still get him done. Now at 21 days, I think stoppers also a challenge. I think you probably with this, as they said, probably I wouldn't do the standard inguinal approach with this case. Doing this with smaller windows, especially in obese patients and somebody who's already had so much risk. Okay. Reasonably fair reduction, we tackle the because of the large anterior wall column fragment that we could reduce down. The medial wall was stuck. We did not go about tackling that around at 21 days. He's back to walking. This is still early days, but at least this is happy for him around the line. Okay. So I think finally to summarize, I think complications are probably an integral part of acetabular fracture surgery. Try to identify them and manage them. And I think it's important to avoid if it's possible, because I think they have morbidity and mortality issues. I think as you as a surgeon probably needs to do good planning. You need to innovate, learn new tricks. I think percutaneous techniques need to be practiced because these are things which are riskier. But you need to constantly evolve as acetabular surgeons to avoid complications. So let me summarize with this case. This was anterior. This was a both column fracture with somebody who had an electric burns also. He had a sciatic nerve pulse. This is him at 2 years. And then his sciatic now, at least his tibialis anterior component is recovering. His EHL is not recovered, but this is about a 2.5 years follow-up. So I think follow-ups also are your long teachers for acetabular surgery, especially with complications. Thank you.
Thank you very much, sir, for such a comprehensive coverage on the complications. So now we have the questions related to this talk. And
can I take the first question for everybody?
Yes, sir.
So patient has collapsed on table. Anesthetist said he's resuscitated. Would you go on with the surgery?
Dr. Karandikar, yes.
I've seen it 3 times.
Yeah.
You traveled 100 kilometers to do the case.
I think Nirbhay's voice is not coming through. Can I go through? Can I answer to that question, sir?
We take you at last. Let's ask Sarvanan.
Yeah, Sarvanan.
If I would for an acetabular fracture, I will definitely cancel the case. Whatever the travel I would have been involved, probably I would like to reassess the patient. Well, almost everybody would have gone into a general anesthesia. After a general anesthesia, patient collapses. It's something bad, and I would definitely postpone the case and then come again another day, or if at all, if the patient is fit, or try to find out what is the reason for the collapse.
It was spinal, suppose. Kothadia, sir. Yes, Nirbhay.
Sir, my personal choice would probably be to cancel the case, because there's nothing bad that can be made worse by a wrong decision. So if the patient has collapsed on table, there is something else definitely that's happening there which we need to investigate. The urgency is not to operate him, the urgency is resuscitation always. So I don't think there would be any point. Even if I've made a trip of 100 kilometers, I'll just enjoy the drive back home.
No, patient is resuscitated now. Anesthetist said, sir, sab theek hai.
I would still not agree to that. We'll investigate further. There is something we are missing.
Dinesh.
There can be always difference of opinion. So let's hear everyone. How does everyone say about this?
Okay. If the patient is resuscitated in my own institute, I would go ahead. Outside, always a no.
So even in your institute, Dinesh, do you know what is the reason for this collapse? And you have not told your patient relatives don't know, a critical event that's happened.
See, basically, it depends on the level of confidence you have in your anesthetist and the backup you have in the institute.
Sir, can you speak, Dr. Kale, can you speak a little louder? It's a little difficult to hear you, a little far away.
I think it needs to be unmuted.
Ashok.
Unmute. Yes. You need to unmute. So one of the
We
unmute.
have done it. It's not happening.
Okay. Now
Yeah,
can
Ashok. Yes.
Yeah.
See, there are two
I have a question. Like, how many of you do your acetabulum fracture in spinal? I don't feel comfortable, especially with the anterior approaches. Like, I think like you need the bowel to be relaxed. You need the muscles to be relaxed. So I think like doing it in spinal is probably a big no for me unless I'm pushed to that. And one's like, as you said, like I don't think you will have a problem with collapse with regards to GA unless the problem is surgical. So if the problem is related to my surgery in terms of blood loss or something, yeah, probably I may have to abandon it. But if it is
You've not
purely
started
anesthetic,
surgery, Ashok. You've not started
Yeah.
surgery.
in that case, like I will go with the anesthetics. Like if it's like comfortable to go again for me, like I would go again.
Can I chip in actually? If we know the cause of the problem, like if there is because of inadequate preloading or whatever, then we can go ahead. If we don't know why the patient collapsed, it's better to postpone. If we know why it happened and it's something correctable, like simple, they have not preloaded the patient well, or the spinal became high spinal suddenly. We can, if we know the cause, then it's better to then we can go ahead and continue. If we don't know the cause, it's better to postpone, reevaluate, and then do it.
Kothadia, sir. Unmute.
Sir, you have to unmute.
Mute hai.
A minute. Yeah. If the anesthetist is absolutely very sure about this is because of spinal, you can resuscitate and go ahead. If he is also not very sure about the cause of the problems, then we should wait. We should postpone and wait it.
I think the safe bet is to wait.
So, hello.
Yes, Pradip.
Yeah. So the thing is, if the patient has collapsed after the positioning, especially in a posterior column fracture, then there is a chance that the superior gluteal is injured because of the positioning, and then that can cause one of, it's a known fact. However, there are other factors also like spinal and everything. So there is a science and there is a social thing. So in my practice, I would not go ahead with the surgery in this case. I would immediately tell the patient relative that the patient has decompensated and we need to observe. However, I will keep monitoring the patient then and there only. However, if the patient continues to deteriorate in spite of all the things which anesthetist has, then we may have to explore and find out the bleeder. Not for the fixation, but to find out the bleeder.
No, may I chip in? So,
Yes.
Pradeep, what you're saying is preoperative. Dhaval has asked.
No, I am talking about. So I am talking about the intraoperative. There have been cases where just the patient has been positioned and the posterior column.
But if you have not started yet, the patient had some problem and the anesthetist says you go okay. So my take would be the one saying goes that life is more important than limb. So if we cannot ascertain what's the cause of it, we should never abandon it. In my practice, I'm regularly going twice a month to other places like 135 kilometers from my place. So for me, it's not a big deal. If I have to abandon, I will abandon.
But keep on monitoring the patient. That's what I'm trying to say.
So can I throw in? Yeah. So all these three cases, I abandoned the case. All were far off cases. One, we could document a saddle embolus. The other two, we could not document anything on X-ray investigations. And I think if you have a saddle embolus that's happened with the position, you traction gave it and it moved out, then I think it's important, probably, as everybody says, that it will be better off to investigate, I think, counsel, talk to the patients, and then take it up. This is what I feel, but I differ on this.
So I thank you everyone, all the faculty members, and there are few questions from the delegates. So I will just since we are running short of time, I'll just put the important one, and that is for Dr. Kale. Sometimes in a comminuted posterior fragment, they are not very small and not amenable for screw or plates. So what would be your plan in that case, sir? Very crisp answer.
If they are just not fixable and they are too small, it is better to remove them, because these loose pieces, if they go intra-articular, then it's a hell of a problem. But if they are not loose, they are attached to a capsule, You can anchor them with the capsule.
And regarding
yes.
question to Dr. Ashok, any opinion regarding any close reduction maneuver for central fracture dislocation with intact acetabular dome in conservative treatment? If at all you are conserving, of course.
You mean to reduce a dislocated head and then opt for conservative treatment, is it?
Hello? Hello?
Hello?
Both are audible.
Yeah.
I don't see, I don't think like I have done it once. Yes, like I don't think I use that strategy as a preoperative reduction maneuver as well. So I don't think like that is figured in my plan so far.
Can I add something? Can I add something?
Yes, sir.
Actually, there is nothing called
Yes,
as
yes.
central dislocation.
Yeah.
It is a misnomer. Now that we are acetabular surgeons, anterior dislocation accepted, reducible, posterior dislocation accepted, reducible. There is nothing like central dislocation. It is the X-ray picture that is basically involving both the columns. So there is no role of any reduction and then conserving it later on.
So Pradeep, can I take this other question?
Yes, yes. Yes, sir, yes.
Yes. So this one.
Yeah.
So what do you want to do with this one? Guys?
What is his problem? What is his problem?
Restriction of, he cannot sit with figure of 4, otherwise everything else is okay. No problem. Walks well.
It's
No
almost like
pain otherwise.
grade 4 HO.
Yes. But this was, again, as I said, this was a posterior wall that was, we did not cut the rotators. We just slid this plate while we, through the incision of nailing, made it a little more, no detachment. You still got HO. So that's okay. He had probably had head injury also. Take it out, leave it.
Sir, actually, the limited movement of the hip is the reason he is not having pain. Actually, because the head and acetabulum, there is little bit of incongruity. But because the HO has caused it almost to fuse and causing limited movement of the head, he is not having symptoms. If we remove the HO, he may develop symptoms because of the movement of the head. I want to know the other's opinion on this.
Yeah, I think CT
It is
will
required.
help in this question.
He is
Sir,
like,
and
yes,
can you be sure that like this is the reason that he is not able to sit on a figure of 4 position? It could be the hip as well.
yeah, I think so. Or the external gluteal musculature has calcification.
You have any other views?
No lateral on him, but he differed because he came out of a very difficult situation. He had a trachea and everything around. When he was in ICU for 2 months, he has deferred from having anything done for it.
Because if you take an X-ray in wide abduction and adduction, that piece is quite posterior. I don't think it is coming in the way of his abduction.
No, it's not. It's palpable in the gluteal region. Okay. It's palpable spike, like there. But he's not has any major problems with this. So we left him alone at this time. Okay. All right. Over to you, Pradeep.
Yeah. So I really thank all the faculty for their excellent contribution and which has made this first AOPAS VOS webinar a successful event. And I urge all delegates they can see this YouTube video on the AOPAS YouTube channel and post the question there. And all the faculties will be there to answer all their questions in the YouTube chat box when the video is loaded. Thank you very much and have a great Sunday ahead. Have a lot of webinars throughout the Sunday. So enjoy the academic fish for the rest of the day. Thank you.
Yeah, thank you.
See you guys. See you guys. Thank you.
Thank you.
Thank you.
Bye.
Thank you.
And I really thank VOS, Dr. Nirbhay Karandikar, Dr. Chandak and Dr. Babulkar to take this initiative to collaborate with the AOPAS and to bring this thing into existence. Thank you very
And
much.
we want to thank Dr. Pradip Nemade for initiating and bringing us through.
Putting it together.
Yeah,
He has
he's
brought
an
his
excellent
expertise to the fore.
coordinator. He's a very excellent coordinator.
And the master of Zoom.
Yeah, plus Zoom.
Thank you.
Thank you.
So nice.
Ending the meeting.
Thanks.
Okay.